So guys, good day. As I had briefly said before, that we'll be taking up complex clinical scenarios relevant to surgery and discuss them with experts. So this is our first session in which I would be presenting a clinical scenario to my two trusted generals. On my left is Dr. Manish. He happens to be a critical care expert, and from my own alma mater, SCPGI Lucknow, he's in fact the senior most and the only accredited and trained clinical care expert in our region of Punjab. And towards my right is a charming professional, Dr. Radhika. She's the nephrologist, and whatever we do, whatever I do as a GI surgeon is cannot be complete without their help. So I'll be, with this brief introduction, I'll be presenting a clinical scenario which we all surgeons keep encountering day in, day out, and we keep taking random decisions which finally affect the outcomes which are so many times adverse. Our basic aim is to cut down all these random practices so that our outcomes become standardized, and in a very good positive way we achieve patient care. So let's say, Manish and Radhika, we get a middle-aged lady or a gentleman in the emergency room with sepsis originating from the abdomen. So most possibly perforation peritonitis, may it be anywhere. It's neglected in the sense that the patient has been having this complaint for 4 to 5 days, and he did not take any formal treatment. Only informal local treatment has been taken, and then finally when things became worse, he comes to the ER, and what we record is that patient is sweating, he's having tachycardia, tachypnea, BP says 100 systolic, and we invoke our complete resuscitative protocol for such a setting, which includes IV line, catheterization, NG tube, and we put in the catheter, and we get a urine output of say around 15 to 20 cc high colored urine. So what now? The question is, what now? How do you want to proceed?
Yeah, thanks, sir. Sir, as you have told that this is a case of a perforation peritonitis with septic shock. So clinically it looks like perforation peritonitis with septic shock, and we have radiologically we have proven by seeing the X-ray and in the air under diaphragm. So now the patient is it is 3 to 4 days old, so it is an old perforation, so obviously abdominal sepsis with septic shock. So first of all, we have to see the hemodynamic stability and the airway management of the patient. Patient is, so how is the patient's sensorium, how is maintaining his or her airway, and then about the fluid resuscitation, patient, the hemodynamics. First we have to stabilize this. If we will take this patient of perforation pattern directly into the OT, then 100% there will be a mortality on the OT table. So first we have to resuscitate this patient, we have to follow the sepsis bundle, we have to follow sepsis 1 hour bundle, we have to resuscitate the patient with at least 30 ml per kg fluid, but we have to just 30 ml per kg 2 liter fluid. Do not go give it at once. We have to assess the hemodynamics of the patient. Invasive lines is very important. It is must to secure a center line, it is must to secure a arter line. Then we have to depend on the dynamic parameters of fluid responsiveness. Give 500 or 1 liter of fluid, then again check for dynamic parameters like IVC diameter, IVC collapsibility. Of course, after stabilizing the airway, if the patient is maintaining well, we have to target even pre-fluid, we have to do a baseline ABG, we have to see the lactate, and then we have to target the clinical parameters, even the basic parameters like the static parameters, urine output, BP, heart rate, and then we have to go the dynamic parameters, IVC. We have to assess everything, and we have to so in this patient, what is important is, of course, the source control is important, but after resuscitation, after antibiotics, so we have to take the blood cultures of this patient, paired blood culture of this patient in a sterile method, and then we have to give a broad spectrum antibiotics. So as sir said, this is a patient of a perforation peritonitis, so usually we have to give a broad spectrum, the old, so we have to give a gram negative cover as well as we have to gram positive cover and we have to give a anaerobic coverage, and then we have to after resuscitation and broad spectrum antibiotics we have to give, and then we have to proceed further.
Manish very nicely enumerated all the points. But let's restrict this scenario to a peripheral hospital or a single owner surgeon owned hospital where there is no privilege of a nephrologist or a critical care expert. where probably central line may be a far-fetched luxury, arterial line not possible. So in that context, can you remodify or maybe downscale this kind of a scenario so that they can achieve it at their end? Like what kind of a target urine volume would you be wanting, and what kind of hemodynamic target levels would you be wanting?
Of course, these patients we usually face in a peripheral setup, because actually these complex cases should be tackled in a tertiary center with a critical care backup with every resuscitation equipment. But if this patient bounds to come in a peripheral setup, so of course we can resuscitate the patient with a wide bore IV cannula, and we can target the static parameters. We can target a systolic BP, or we can target a MAP of at least 65 to 70. We can target.
So be very clear, MAP is mean arterial pressure. All surgeons should know how to calculate MAP. It's a very simple formula, and you must target MAP rather than the systolic BP which we run after.
You don't have to just mug the formula of MAP. Just a 2/3 of diastolic BP and 1/3 of 2/3 of diastolic BP and 1/3 of systolic BP. Add it, we get MAP. So at least target a MAP of 65 millimeter of mercury, so that you can get a good perfusion out of the body, as well as good renal perfusion, good cerebral perfusion, and good coronary perfusion. And target just urine volume of more than 0.5 ml per kg per hour, and target so that the urine is not concentrated. Patient have free fluid urine, but make sure to insert a Foley's catheter. It is even available in a peripheral, because in this case the hourly urinary output monitoring is very important. And if you don't have an ABG, if you cannot target lactate, just we can do a capillary refill time, CRT. Recent studies have shown that, recently Andromeda shock trial, where it has shown that the CRT is as good as lactate. So even if you cannot do a ABG in a peripheral setup, you can target a CRT with fluid resuscitation.
Yeah. Dr. Radhika, what I would want to know from you is that in this patient, let's bifurcate the clinical scenario. One is that there is no background renal disease. So the patient is having an upfront urine volume of 15 to 20 in the catheter. What kind of antibiotics would you allow me, and what kind of antibiotics would you not allow me in this setting at the outset? The second scenario is that the patient is having a background renal disease. Is that the patient is a diabetic and already in some kind of a chronic renal impairment. So what kind of adjustment of fluids or antibiotics are there in both the clinical scenarios?
So thank you so much for the wonderful discussion, and Dr. Manish has told us in detail how beautifully we can manage this patient. So coming to the nephrology part, so first of all, it is very important to secure a good urine output. As sir said, that 0.5 ml per hour is the adequate amount of urine that we need in the patient. Coming to the first scenario, if the patient is an AKI, that means there was no previous history of any kidney disease, then in this patient I would classify it in a AKI stage 3, that means nearing the renal shutdown. So with such a patient, the mortality, if you plan to take up the patient in the OT, the mortality increases to 60% in the face of renal shutdown or in AKI stage 3. So the mortality rises by 60%. So I completely agree with the sir that we should go for a broad spectrum antibiotics and stabilize hemodynamically the patient, achieve a MAP of 65, adequately fluid resuscitate the patient. That is very important. One thing I would want to stress, that in a peripheral setup, when usually we don't get a urine output, everybody wants to give a shot of Lasix 10 mg and then move forward.
Very important.
Kindly please adequately fluid resuscitate a patient before giving Lasix. So we do not advocate giving Lasix or Ditor before adequate hydration of the patient. So the diuretics are only meant when there is a fluid overload, otherwise not. So first, if you have a setup where an ultrasound or an echo is available, kindly look at IVC. It is very easy and we can monitor it maybe twice a day or thrice a day, and we can adequately fluid resuscitate a patient. If not, we'll rely on the peripheral signs like skin turgor, creps in the chest, pedal edema and other signs, dryness of tongue, and we'll adequately hydrate the patient, then monitor the urine output. Coming to the antibiotics part, in an AKI patient, we do not withhold an antibiotic except for aminoglycosides. So I would urge that if the creatinine is high, whether in AKI or whether in a CKD patient, you don't have to get an NSAIDs, do not give any kind of aminoglycosides, rest you can all give. So the broad spectrum antibiotics that we usually prefer, it can be a cephalosporin, maybe a third grade generation, or maybe we can go for a piperacillin or tazobactam. You have to give it in full dose in an AKI patient. We also want to give a gram-positive coverage. Give in a full dose. Metrogyl has to be given in the full dose. So Metrogyl, specifically coming to the GI intraperitoneal infections, if we talk about, till a GFR of 10 ml per minute, the dose of Metrogyl remains the same. So you have to give it in full dose. Less than 10 ml per minute, we may reduce the dose by 50%. So coming to a scenario where the patient is already in a known case of CKD, coming with an acute and chronic disease with such complications such as in sepsis, with hypotension, with intraperitoneal infection, with multiple organ involvement. In this case, the mortality definitely is very high. In a CKD with a creatinine of more than 1.4, it is documented that it can be chances that patient goes into renal failure perioperatively, that is intra-op, or maybe just out after the surgery, and they may even require some kind of renal replacement therapy support also. So we have to keep in mind, we should have all the the machines or the facility available if we are going to operate on a patient who has a high creatinine, especially beyond 2.5. So we must have the facility available
for hemodialysis or CRRT or
yes,
that.
Because beyond a creatinine of 2.5, see, the GFR depends on the age of the patient. But beyond a creatinine of 2.5, usually the renal reserve is somewhere around 25-28 ml per minute, and it is already in CKD stage 4. So such kind of patients may require renal replacement therapy in the perioperative period. Plus, we should also be aware that what was the baseline creatinine of the patient, which is very difficult to discern in those areas, in those hospitals, because the population sometimes may not be aware or may not be in the continuous follow-up that what is the baseline creatinine of the patient. And antibiotic dosage should be adjusted according to the disease level. What was going on maybe a month before or 2 months before, what was the creatinine level, calculate the GFR and adjust the antibiotic dosing according to that, not on the current creatinine.
Is a single shot of amikacin allowed? Like, we surgeons are in absolute love with amikacin. I mean, immunoglycoside, it's like our maybe just as a chef uses black pepper or salt in the kitchen, amikacin is that to us. Is a single shot of amikacin allowed, or is it not allowed till we have the biochemistry parameters and the renal function parameters with us?
I would usually do not allow an amikacin shot. The basic mechanism of amikacin is causing the tubular toxicity. So in the phase, if the patient is in AKI stage 3, already the preglomerular parameters and the hemodynamic parameters are compromised. So the microcirculatory.
So that means till we have all these parameters with us, or till we have a good urine flow going, we should avoid amikacin.
Yes, we are.
Once, if suppose we establish a good urine flow with hydration, as he said, is amikacin then allowed, or we would still abstain from it?
So in a CKD patient, amikacin is an absolute no.
Okay.
No, in an absolute
despite
no.
urine output is there.
Everything. In a CKD patient, amikacin should never be given, whatever the creatinine may be. In a phase of AKI, if the patient has the creatinine coming back to the normal, so if the patient has a history of AKI, with now creatinine coming back to the normal, the patient is prone to having subsequent AKIs again and again in the coming future.
Alright.
And such a patient who had an AKI is prone for CKD in the coming years also.
So that means Manish, with her absolute no for amikacin till the time urine output is established, or till the time or in patients of CKD, I think we cannot use amikacin at all. So what should be the antibiotic of choice in such a setting? Peptaz maybe?
Yes, sir. Actually, we try to, whether it's a prerenal AKI or a sepsis-induced ATN, we try to avoid all nephrotoxic agents. Either aminoglycoside or IV contrast agent or anything, or diuretics in a prerenal phase. So if we have to give antibiotics, example we are giving, let's say Peptaz is the most workhorse antibiotic. It also has an anaerobic coverage. So usually for people try to combine Metrogyl with Peptaz, which is actually wrong.
I will just hold on for a moment. As a surgeon, when there is a perforation and there is anaerobic, totally flooded anaerobic organism, we generally use two drugs. That is generally we combine Metrogyl with Peptaz. because we are apprehensive on that account that it's a massive sudden overload of the system with anaerobic. So that's our logic of combining metrogyl with peptaz. But as you said, it's totally right. Peptaz has a good anaerobic spectrum.
In abdominal perforation peritonitis, even I will add metrogyl with peptaz because metronidazole has a broad anaerobic coverage.
Yes, yeah.
It has a peptaz, BLI has an anaerobic coverage, peptaz, but not that broad as metronidazole. So in case of abdominal perforation peritonitis, we will add metronidazole. Now coming to the antibiotics, people tend to, if there is oliguria of patient is having no renal history and the creatinine comes to just 2, people tend to modify the doses of antibiotics. Yeah. So this is wrong. In the patient in sepsis, the time is money. Huh?
Yes,
so
it's a kind of emergency.
Yeah. So the most of the antibiotics which we use in the ICU are time-dependent antibiotics. So the most important concept in using a time-dependent antibiotics, we have to give a loading dose. Huh? We have to loading dose, and that loading dose is given over 30 minutes. Example, we are using a peptaz. We have to give a peptaz of 4.5 gram over 30 minutes. It's a loading dose. And after the end of loading dose, we have to start the maintenance dose after the end of the loading dose only. Right. So in that case, if after resuscitation with IV fluids, patient is holding a good urine output, even if the creatinine is 2 or 2.5 or 3, I am not going for first 48 hours. I am not going to modify any doses of the antibiotics. We have to give full dose because we have to hit hard from the beginning. So apart from the source control, this is also important.
So let's see, if the patient, you start the peptaz at 8. Till 8:30 a.m. you gave peptaz. Yeah. Then the next dosage would be 8 hours after that?
Yeah. No. Next maintenance dose will start after the end of the loading dose.
Exactly. That's what I was coming. So that means it's going to be a double dose.
Yeah. And that in an infusion dose because the patient is in shock. So in these patients are shock, circulatory shock due to any reason, prolonged infusion are recommended. So
how long will be that maintenance dose?
It depends. It depends on the antibiotic to antibiotic. Example, apart from this infusion dose, the infusion dose time also depends on the stability of the drug in a solution. Example, imipenem. If we come to the imipenem, cilastatin with the carbapenem. So its stability in a solution is only for 2 hours. So we usually give it over 2 hours. But doripenem is stable for 4 hours. So we give it as an infusion over 4 hours.
So that means maximum stability till the time the drug is maximally stable, we'll utilize that full time.
Yeah. Because in time-dependent antibiotics, there is a concept of T greater than MIC. So we have to achieve that. So we have to keep the concentration of the antibiotic for the maximum time. It should be more than the MIC level of the drug. So that's why we prefer drugs in infusion. So for peptaz or BLI, usually we give it as a 2-hour infusion.
Okay. So first dose loading was half an hour
over 30 minutes,
and then 2-hour infusion
PDS
in 100 cc saline or something. 8 hours.
Yeah. If we have infusion pump or a syringe pump, then we can, example, we take in a 50 ml and we give it at 25 ml per hour for 2 hours.
For 2 hours.
Yeah.
I hope you have no objections about peptaz. It's renal safe.
Yes.
It has.
In AKI, give complete dose.
Yeah.
So it is 4.5 grams 6 hourly. And in a CKD patient, we will definitely, after hitting hard and giving the loading dose,
then you have to modulate peptaz dose in a CKD background.
Yes, usually with most of the antibiotics in a CKD patient also, we give a full dose of loading. So loading remains the same.
Loading remains the same, but maintenance dose will be modified depending on the GFR.
Because the loading dose depends on the volume of distribution, and the maintenance dose depend on the metabolism of the excretion. So loading dose remains the same in every patient.
Okay, Manish, suppose there's a rampant practice in the periphery of starting meropenem as a first drug. It's a fashion now. What is your take on that practice?
Yeah, sir.
I too would, in certain settings, would go in for meropenem as a first drug, but I would want to listen to you what you have to say about meropenem as a first drug in a patient who has just come to the hospital for the first time.
Yeah, so it depends. There are two scenarios. If the patient is having one patient is coming from the community for the first time, the patient is coming from the community in the hospital, and second patient is a known CKD patient on hemodialysis, or patient is taking treatment from from hospital every 2 to 3 months, or coming from small centers.
Where already some antibiotics have been given and referred for further.
In that case, so in the first scenario, the patient coming from the community, don't directly jump to the carbapenems. We can start with the BL-BLI or just with the cephalosporin. We can give, and now the recent studies have shown that initially the drugs for community acquired UTI, example is for community acquired UTI, normal cephalosporin was effective, BL-BLI was effective, but now the ESBL in a community is increasing. So now various studies are showing that for ESBL, even community acquired UTI, directly go to carbapenem. But because in 2008, 17, 18 randomized controlled trials have come from the famous is the Merino trial, which has come in 2018, and it showed that carbapenem is the drug of choice. Carbapenem is drug of choice for ESBL organisms. So for the after that, the practice of using carbapenem has increased a lot, but the carbapenem resistance is increasing.
That is coming now in a big way.
So CRE organisms are increasing. Carbapenem resistant enterobacteriaceae is increasing at a very rapid pace. So now we are saying that try to use 4 generations cephalosporin, in which recently the Cipla has launched cefepime and metazobactam, which is a new drug, and it covers ESBL. So these are the carbapenem sparing drugs. So we
should use them one step before carbapenem.
We can use as empirical therapy.
Yes.
If the patient is, if you don't want to use BL-BLI, so you can directly as empirical therapy you can go on that drug, which is a 4 generations cephalosporin, and it also covers ESBL. So of course sometimes patient is in shock, and we are quite afraid we might lose that patient.
Yes.
So
that window period of survival is going to be very this is the last hit, if we succeed, it's good, otherwise patients go.
So in that case, if somebody is starting carbapenem and targocet as a broad coverage, so it is not bad, but try to de-escalate and give a targeted therapy as soon as we get the culture reports, or if we are following some sepsis markers. Example, we follow the CRP and the serum procalcitonin. If the procalcitonin from the admission, if somebody has done procalcitonin on the admission, it decreases by 80% of the baseline, and patient is quite good, and we have done the source control. So try to de-escalate the antibiotics. If we are able to get the culture, so it is well and good. So if we are giving a broad spectrum carbapenem, even there is no harm, but try to de-escalate as soon as we can.
In a scenario where the blood cultures have returned to be negative, but these markers are still high, procalcitonin or CRP, would you advise de-escalation, or would you advise the same antibiotics to continue?
If the patient is clinically good, and I have already said that the procalcitonin has decreased by level 80% of the baseline, so we can
then only. If procalcitonin is not decreasing, that means we have to continue our initial antibiotic coverage.
It depends on the clinical condition of the patient. We have to note not only just biomarkers, not sepsis biomarker, along with the clinical condition, we can take a decision that. But various studies have shown that in a patient with a source control, usually not more than 4 days of antibiotics are needed.
Not more than
4 days of antibiotics.
4 days of antibiotics.
So if we have done a good source control and we are confident, and so 4 days antibiotics are more than enough. So the studies have various studies have targeted antibiotic course of 4 days versus 7 days.
7 to 8 days.
7 to 8 days, and they have shown that the 4 dose antibiotic is as good as 7 days antibiotics. We can go on that part.
That's right. And the other thing is that as a surgeon, we love to get a CT scan, and I would definitely want a CT scan in my patient before I take up any patient for surgery, because if at all nothing else is given, it makes me sure that nothing more is there. For diagnosing a perforation, simple, we don't need a contrast enhanced CT scan. A good clinical examination, or maybe an X-ray or even a plain CT would be enough. But many a times we need a contrast enhanced CT scan. So Dr. Radhika, what is exactly the contrast dilemma which you face in such patients? At what level would you allow me or the radiologist to give IV contrast? In a pre-renal AKI, is a contrast CT, IV contrast CT allowed or not?
So contrast is known to cause hyperosmotic damage to the kidney in a pre-renal form, which is a hemodynamic instability for the microcirculation. Then it can also cause tubular toxicity, and it may also damage kidney in some other forms also. So there are 3 to 4 mechanisms which can, the contrast can damage the kidneys. Earlier we used to, completely not allow giving contrast when the creatinine was high, but nowadays we have some studies which says that contrast may not be affecting or damaging the kidney in such a way, and nephrologists were, more scared.
Overprotective.
Yes, overprotective is the right word. So now we have a new term coined which is called contrast associated nephropathy, and it is no more called contrast induced nephropathy. So there is a change of terms now. So contrast associated nephropathy means that contrast may not be the only sole cause which is causing the creatinine to rise. There may be other parameters also which are making us believe that this is causing the kidney damage. For a patient in CKD who is already having a GFR, less than maybe 60 or whatever, I will never allow IV contrast. First of all, we should know that oral contrast is not a problem.
That's not a
kidney.
problem. Yes.
So oral contrast can be given at any creatinine, but IV contrast we do not want to give in a already known CKD patient. For an AKI patient, if the creatinine is high, please avoid IV contrast until and unless it is a life-threatening situation. If it is a life-threatening situation, you can go ahead. We have other parameters to manage the kidney. If the AKI has settled, the creatinine has come down to 0.8 or 0.9 or 1, there is a question that okay, now the contrast is creat is 1.2 or maybe 1.3, which is within the normal range of our laboratory. So can we go ahead with the contrast? I would not want to, because we would want that creatinine should come down to baseline, then wait for some days, and then maybe we can do a contrast study if the patient can
it's required,
wait.
yeah.
If the patient can wait, that is the ideal scenario. But if the patient is in such a situation where it is an MODS and in the perforation and waiting for the surgery, then there is no point waiting.
Okay.
But it will definitely damage the kidney to some extent. It may lead to rise in creatinine. How would we know that? Maybe, the creatinine starts rising after 3 to 4 days, gets a peak after 7 days, or comes down later.
Is this rise in creatinine from contrast an irreversible damage? Because I've seen so many times with you also, you say, sir, you go ahead with the contrast, we'll do a hemodialysis. What is that part like? I mean, does it push the kidney irreversibly into further damage, or it's a reversible insult which is temporary?
It is a temporary insult. It is definitely not a permanent one.
Okay.
So what sir is talking about dialysis is when the GFR is very low. I would say maybe less than 45. There is no exact figure related to that.
GFR 45 would correlate to a creatinine of or around how much? Because we are surgeons, like we would not go into a calculation of GFR every time.
Somewhere
by and large.
1.8.
1.8. Okay.
So roughly, because
Roughly,
it depends on the age and the male and
yes,
the female
yes.
gender and
I
the
totally
muscle
agree.
mass.
So around 1.8 is.
Roughly, I would say 1.5 to 2. You can take it as a
Okay.
range. So beyond that, when the creatinine is, I would say beyond 2, and if the age is beyond 60 years, we have a natural kidney reserve coming down.
Yeah.
So the body might not be able to wash contrast in such a nice manner. So if the in some cases, if the creatinine is beyond 3.5, the kidney would not be able to excrete contrast. Contrast is a very highly osmotic agent. It is lying in the vessels, traveling in the kidney, is not able to filter that.
All right.
So how do? We do a dialysis session. The dialysis machine will filter it out, and the body will, just come back to the normal.
So if that means that if there is a pressing indication for a contrast due to whatever other reason we may have, IV contrast is mandatory, then we have an option of giving the contrast and handing the patient over to you for a hemodialysis.
Such a situation will usually arise if the creatinine is near 3.5 and 4. We've given a contrast, the body is not able to throw it out, and the urine output is like 10 ml per hour, 5 ml per hour, 15 ml per hour. Then if the other complications start to develop, like metabolic acidosis is coming in the picture, hyperkalemia is coming in the picture, we'd like to give a short session maybe of 2 hours.
2 hours.
That will clear out the contrast, and whatever the baseline reserve of the kidney was there before the
They'll
contrast,
come back to that.
the patient should come back to that.
part.
And if the other all parameters are sorted, like hemodynamic stability is achieved, pre-renal hypoperfusion is not there, and no other NSAID has been given, and there has been no other insult with another agent, so the kidney should come back to its
normal function, which was like just before the insulted was.
Previous stage.
Manish, now the scenario is, I think we are concluding this clinical scenario. Now I'll give you one last setting in which we've transferred the patient under your care. and we are waiting surgery, but the urine output is not picking up despite everything. Despite everything means you hydrated the patient, you put the patient on antibiotics, source control is awaiting. You've tried everything, but the urine output is nearly 5-10 cc per hour. Would you still push me for doing surgery as a last resort, or would you keep waiting? Because now we have only two options. Either is one to go in for surgery as a high risk case with a complete informed consent of ventilation, of hemodialysis and all that, and mortality, or would you still keep waiting without allowing me surgery?
Yes, that is a very good question. Okay, if we are assuming it is a perineal AKI and we have hydrated the patient and we have checked all the dynamic parameters and IVC is up to a good level, the collapsibility has decreased.
Very important. This part is very important. This means that the hydration part has been taken care of, not before that.
So and still the patient is having not good, pouring a good urine output, and we will think, okay, what is the reason? Whether the ATN has settled, renal AKI has settled, or it may be a case of abdominal compartment syndrome. It may be a abdominal compartment syndrome. Patient is a perfusion peritonitis and there is a fecal peritonitis and everything. There is a intra-abdominal hypertension. So
acidosis is there.
Acidosis is there. So there are a lot of, but we cannot wait for surgery. We have to do a source control because otherwise the mortality reaches 100%. So we have stabilized the patient. The patient is stabilized. The lactate has come down. The patient hemodynamic parameters, perfusion has optimized. Then the source control is the most important part. We have loaded the patient with antibiotics. Everything has been done. So we can start a diuretic. We can give a diuretic. Of course, we have to see the hemodynamics, and then we have to take the patient for surgery.
So that means even in this situation where things are not going the right way as far as kidneys and hemodynamics are concerned, you would still suggest that you go in for surgery with all explained risks.
Yeah, definitely. And otherwise, we will lose the patient. One organ dysfunction we can afford. Of course, patient can go into CKD, but we have to first salvage the life of the patient. It is very important. Otherwise, we will lose the patient.
Okay. And the other thing which we left, this totally we've not taken, which we probably in a subsequent session we'll take up, is the role of pressors, the NORAD and vasopressin and all that stuff in relation to the kidney and all that, because they also have a counterproductive effect on the kidneys. So that probably we'll take a separate session on that. So thank you, Manish. Thank you so much for helping us out on such a complex scenario with such clear and succinct guidelines. And thank you, Radhika. So nice of you.
Thank you.
Thank you.